This is the part 4 of the video HIV infection with AIDS and Pneumocystis pneumonia. We continue with the last video.
Used is the beta-glucan, primarily because it's a non-invasive test that is becoming more readily available. When I was in fellowship, Paul Sachs and I did a study where we looked at patients in the ACTG 5164 trial, which was a trial comparing early versus later treatment of opportunistic infections. And we looked at all those patients in that trial who had a beta-glucan and had respiratory symptoms, and we looked at whether or not they had PCP, and we found a sensitivity of almost 93%, slightly lower specificity, but a very high positive predictive value of 96.3%, and a negative predictive value of 60%. What I've found in talking to people about beta-glucan is that it is very helpful if there's a fast turnaround time in getting the result. For centers where it's still a send-out, where there's going to be a long delay getting it, it probably is not going to be that useful, particularly if you can get a bronchoscopy and BAL even quicker. For centers who are running it in-house, who can get a result within 24 or 48 hours, it's really made a difference in diagnosing PCP. And I think once it becomes more widely used and is done in-house in more centers, more will start using it. So just to summarize the diagnostic evaluation, of course, starting with a chest x-ray makes sense. If it's normal and there's a high suspicion for PCP, a high-resolution chest CT can be very helpful. Remember that about 25% of cases of PCP have a normal chest x-ray, but there generally are still abnormalities on the chest CT. And ABG is very useful, both with diagnosis and with determining if a person needs corticosteroids as part of their treatment, and I'll talk more about that next week. I talked about beta-glucan, which I think is very useful if there's a fast turnaround time, particularly if it's run in-house. If it's a send-out, it's going to take a week to come back, and it's probably not going to be useful. And I talked about some of the advantages and disadvantages of LDH. An induced sputum is generally the next step if there's suspicion for PCP. Remember that an expectorated sputum, a non-induced sputum, really isn't useful because it has such a low sensitivity, but an induced sputum is the right next step. If that's negative, what I do is I go right to bronchoscopy or BAL. If you're in an area where the induced sputum isn't performed that well, you don't have much confidence, you could consider repeating it. But really, I think in most cases, the right next step is going to bronchoscopy and BAL. And if there's still a high suspicion, it's still unclear, then lung biopsy is the final step in that process. This photo is an immunofluorescence of pneumocystis from a respiratory sample. So I will stop there and take any questions, and next week we'll move on to the prevention and treatment of pneumocystis.
Now, finally the conclusion. PCP is still the most common opportunistic infection in HIV-positive people. Those with a CD4 cell count less than 200 are at highest risk. 30% to 40% of HIV-positive people develop PCP if they wait until their CD4 cell count drops to around 50 to receive treatment. PCP is still a major cause of death in AIDS patients in the United States. PCP is a very treatable and preventable infection, so if you wait too much time to detect the symptoms already mentioned, you could die. Thank you.